Hi, everyone, and thank you for joining us. My name is Michelle, and I'm here with my colleague, Erin, from your Northwestern Alumni Association. We will begin shortly, and we're so pleased that Dr. Lucas Buchler could join us for this great topic. But first, a few housekeeping items. If you have any questions now or during the presentation that you would like to ask Dr. Buchler, please feel free to use the Ask Your Question box on the left-hand side of your webinar dashboard. Just type in your question and hit send. We will keep an eye on those questions and ask a few of them at the end of the presentation. You will also find some great resources included in the top tabs of the webinar platform. Please feel free to view this information at your leisure. Should you have any technical issues during the webinar, please refer to the Technical Issues tab to see if your question is listed there. Most issues can be solved by just refreshing your browser. Lastly, a link to a recording of this webinar and survey will be sent to all registrants after this talk. Now I will introduce Dr. Buchler. Dr. Lucas Buchler is an orthopedic sports medicine surgeon at Northwestern Medical Group and assistant professor of orthopedic surgery at Northwestern University Feinberg School of Medicine. He specializes in complex knee surgery, cartilage restoration, and shoulder and elbow conditions. He serves as an assistant team physician for the Chicago Cubs with a focus on treating throwing athletes and is committed to helping patients of all activity levels stay healthy. Dr. Buchler plays a key role in education as the Associate Program Director for the Orthopedic Surgery Residency and a faculty member for the Sports Medicine Fellowship. A graduate of the Master of Science in Clinical Investigation program, he is also engaged in research infrastructure development and outcome tracking within the department. Now I'm going to hand it over to Dr. Buchler. Thanks so much for being here today.
Thank you. I appreciate it. So thank you again for the wonderful introduction. So the title of today's talk is The Evolution of Ulnar Collateral Ligament Injuries in Tommy John Surgery in Throwing Athletes. So we'll get right into it here. So I do have some conflicts of interest to disclose. None of these are particularly pertinent. The only one that is potentially pertinent is that I have done some consulting for Arthrex, who does make some instruments and products used in ulnar collateral ligament surgery. But otherwise, I don't think there's anything pertinent here. So the goals of today's talk. So we'll do a brief discussion of my background. Most of that's already been covered in the introduction, and so we'll breeze through that pretty quickly. But we'll plan to get through some of the anatomy and biomechanics of the ulnar collateral ligament, a history of ulnar collateral ligament injuries, especially in throwing athletes, the origin and birth of the quote-unquote Tommy John surgery by Dr. Frank Jobe in 1974, the evolution of surgical management of these injuries over the last 50 plus years now, understanding risk factors for this injury. We'll go through a quick case example of applying these topics to a young athlete, and then talk about prevention and future directions. Please feel free to submit any questions, comments, anything of the above in the chat. The team here will be monitoring that, and we're certainly happy to pause and take a break and interrupt and get to those things during the talk, but we'll also save the last 15 to 20 minutes for question and answer so that we can review some of those and get through the more pertinent topics to you all. So briefly about me, I am originally from the Midwest. I went to undergrad in DePauw University in Greencastle, Indiana. It's Division III liberal arts school, and I played baseball there. So I have a background and have been around baseball for most of my life. I did medical school at Indiana University School of Medicine, and then I came here to Northwestern for my residency. I left for 1 year and went to Steadman Hawkins Clinic in Denver for my fellowship in sports medicine and helped take care of the Colorado Rockies and the Denver Broncos while I was there with the group out that way, and then came back to Northwestern as faculty here in 2019. We talked about the graduate school a little bit there earlier in clinical outcomes and the Master of Science in Clinical Investigation. But I have a particular interest in throwing athletes. I was a baseball player and I've been around baseball for a long time. And so I've always had an interest in throwing injuries and throwing athletes, and currently apply that as one of the assistant team docs for the Cubs. So we get to see a lot of this and manage a lot of these injuries, and all of us across the league. This is a rapidly evolving field, at least when in terms of the pace of medicine in general. So we'll skip through some of this. My other academic interests are largely in clinical outcomes research, clinician and physician well-being and wellness, but that's not directly pertinent to the topic here. So getting to the substance of this talk, again, the title, Evolution of Ulnar Collateral Ligament Injuries and Tommy John Surgery in Throwing Athletes. So I think first and foremost, why is this important? So why is this a pertinent topic? And really, it's a pertinent topic for a select group of athletes, most common and most popular and most discussed. And really, the focus of today's discussion is baseball. Overhand throwing athletes are where we see these injuries. But there's been more pertinent examples of this in other throwing athletes, quarterbacks in football. You see these injuries in javelin throwers. And frankly, ulnar collateral ligament injuries in and of themselves are incredibly common in a lot of athletics. Almost 50% of NFL football linemen have had ulnar collateral ligament injuries at some point. What is very unique to overhead throwing sports is the reliance on the ulnar collateral ligament, and we'll get into some of that in the next few slides. So you certainly hear the most about this, and it's been published the most as it relates to baseball, and especially professional baseball. These injuries are becoming more and more common. And it's a little bit unclear if they're truly becoming more common by incidence. Are they actually happening more often? Are we better at diagnosing them? Or is it that now that we have a treatment, we're more apt to diagnose these rather than someone moving on with a different skill set? So this was a unique, revolutionary, and incredibly innovative treatment 50 years ago, but now it's a very routine part of managing injuries in overhead throwing athletes. So thousands of players have been treated surgically with ulnar collateral ligament reconstruction just at the professional level, and that doesn't include at the amateur and youth level. So the rates of these injuries continue to climb annually. This has been deemed by both Major League Baseball and by the popular media as an epidemic, the Tommy John epidemic. And we'll get into some of that in later slides, but these injuries are happening more and more often. They're happening both with high profile players as well as young athletes, high school and even middle school athletes are sustaining these injuries. And so it's a big problem in the sports medicine world. But again, it's a very narrow part of that world. It's just these overhead throwing athletes that really need to accelerate their arm with speed. Not every single ulnar collateral ligament injury has to be managed surgically, and not every single ulnar collateral ligament injury is career ending. Like I just mentioned, there's a lot of sports where if these injuries happen quite a bit and the athletes are able to recover from them with non-surgical treatment and get back to high levels of performance. So to start with anatomy and biomechanics. So what is the ulnar collateral ligament, or more specifically, the medial ulnar collateral ligament? The Tommy John ligament is the medial side of the elbow. It's on the inside of the elbow. And the reason that's important is there is actually a lateral ulnar collateral ligament as well. We just don't talk about it nearly as much because it's not injured as often and it's not nearly as pertinent for the throwing athlete. So when we look at the anatomy of the elbow is a hinge joint for simple terms. The mechanics of it are a bit more complex than that, but in simple terms, it's a hinge joint, and it's made up of three bones: the humerus in the upper arm, and then the radius and the ulna in the forearm. And so the ulna is responsible for the hinging motion at the elbow, and the radius is responsible for the rotation of the forearm through pronation and supination. So turning the palm up and the palm down is the responsibility of the radiocapitellar joint. So when we look at the medial stabilizers on the inside of the elbow, there's a few major structures. So the first and foremost is the flexor pronator muscle group. That's the superficial layer, and that's what's pictured here is the flexor pronator group. And you can see that on the inside of the elbow. And that's the muscles that flex the fingers and wrist, as well as turn the hand into a pronated position. So turning the hand from palm up to palm down. All of those muscles attach at a common origin on the humerus called the medial epicondyle, and that lays right over the top of the ulnar collateral ligament. We consider that a dynamic stabilizer, meaning that it can move. Muscles are dynamic; they're constantly changing in length and tension with contraction, and so those are dynamic stabilizers. Deep to that is the medial ulnar collateral ligament complex, and we call it a complex because it's not just one structure. All of these structures shown in this image are part of the medial ulnar collateral ligament. So there's the anterior bundle, the posterior bundle, and the transverse bundle. When we talk about ulnar collateral ligament injuries in throwing athletes, we are talking about the anterior bundle primarily. So the anterior bundle is divided into anterior bands and posterior bands. So there's two segments there. And then we divide the ligament into thirds. There's proximal third where it attaches to the humerus, distal third where it attaches to the ulna, and then the middle third or the mid substance of the ligament. This ligament is primarily responsible for resisting valgus force. And what that means is that as an athlete goes to throw and the elbow tries to bend with the hand drifting away from the midline, If it wasn't for the ulnar collateral ligament and the flexor pronator group, the elbow joint would just open right up and the athlete would be able to maintain no energy or force to propel the ball. And if you look at high-speed imagery of the elbow, the amount of force that goes through the elbow with a throwing motion is truly incredible. So the force that goes through the elbow, if you watch, and if this in the middle portion of this image, as that elbow lays all the way back into external rotation, we call that the late cocking phase. That is the phase of throwing in which the elbow sees the most force and there's the most torque on the medial aspect of the elbow. What is truly incredible to me is that the amount of torque created in the elbow when a pitcher throws the ball at the speeds that we see at the professional level overwhelms the native strength of the ulnar collateral ligament routinely. The ulnar collateral ligament, if you take it in a lab and stretch it until it tears, can't get near compensating for the force that's put through it in a throwing motion. And what that we've learned from that and what we know about that is how important those dynamic stabilizers are. The muscle group, the flexor pronator, is able to offload a ton of that force to protect the ligament. And when we see these injuries, it's because of a failure of both of those mechanisms. Either there's a direct injury to the muscle group where the tendon or the muscle is injured, or an indirect where the muscle just doesn't fire at that exact right moment, and the amount of force put through the elbow overwhelms it. But the amount of force put just purely through the hand is over 40 pounds of force when we're throwing a ball that weighs much less than 1 pound. And so this is a very forceful motion with a ton of energy. And it makes sense, right? We see professional baseball players who are routinely propelling the ball between 90 and 100 miles an hour. And at this point, we're even seeing that at the youth level. And so this is a very efficient, energetic motion. The pitcher is able to generate a ton of force from the ground up from their feet and use their musculature through their core and their lower body to translate and transmit that force to the upper extremity. And then the upper extremity is entirely reliant on that flexor pronator group and the ulnar collateral ligament to maintain that force to propel the ball forward with a high velocity. And so it's a very, very efficient motion, but it's also a motion that really presses the elbow up to its limits. And so on a routine basis, pitchers are pushing right close to the level of injury and to the rupture of an ulnar collateral ligament. So what is the history of ulnar collateral ligament injuries or Tommy John injuries? So these injuries present in two varieties, and I think these used to be thought of as almost always the acute variety, where there would be a pop. A pitcher would throw a ball, they would feel something pop in their elbow, and they would be unable to throw. Sometimes pitchers will describe electric shocks traveling through their forearm, and the reason is that the ulnar nerve travels right next to the ligament, and so when the ligament ruptures and the elbow gaps open, the nerve gets stretched. Those are the acute variety, and we still see those. There's certainly still the acute variety of the ulnar collateral ligament injuries, but there's also the more chronic varieties, which is more of an attritional change over the medial elbow. And we'll get into some of that later in the talk, but traditionally these injuries were diagnosed only when there was the acute tear. But there was a lot of people with chronic medial sided elbow pain that limited their ability to throw. That was not an acute rupture of the ligament, but was probably an insufficiency injury to the ligament where the ligament just couldn't quite provide the force resistance necessary to provide that the energy necessary to propel the ball. And so these athletes will present in one of two varieties, either with the acute pop and inability to throw, or a subtle pain across the medial elbow that's gradually worsening, eventually leading to loss of performance and velocity, and ultimately with the athlete needing either some period of rest or feeling like they can't pitch at the level that they would like to. We assess them by physical exam. Most of these injuries can be diagnosed by history and exam. We see this very commonly with athletes that present with medial elbow pain that's preventing their ability to perform. They'll often have pain with a variety of medial stress exams, whether it's a bounce test or a moving valgus stress test or a milking maneuver, but there's a variety of maneuvers that stress that inside of the elbow, that pull the elbow back and stretch the inside. And athletes that have a diminished performance and pain on the medial elbow with positive exam findings almost universally have some amount of ulnar collateral ligament injury. The usual next step is to evaluate this. We will typically get plain x-rays, but the real diagnosis comes from an MRI. And there's a variety of ways the MRI can be done. Traditionally, this was done with what's called an MRI arthrogram, where we inject dye into the joint. That allows us to delineate out any area where the dye is leaking through that medial ligament, indicating that there's a tear in the ulnar collateral ligament. And so historically, these have been career-ending injuries, at least the full thickness ones. So if you go back 50, 60 years ago, this would have been considered a career-ending injury. And you would hear this routinely. Oh, there was this pitcher, and he or she was very, very good, and then they blew out their elbow. And the blown out elbow was the ulnar collateral ligament injury. And it was thought to be an unrecoverable injury, especially the full thickness injuries. Now, there's certainly a role for non-surgical treatment with partial tears, and many of those injuries the athletes could recover. But in the setting of full thickness injuries, this was considered career ending. And so if an athlete blew out their elbow and had a high grade medial collateral ligament injury, we would try to rehab them. We would treat them with a period of immobilization arrest and do our best to allow the ligament to heal, and then try to progress them back to throwing. But very rarely was that effective in a full thickness injury where the full ligament, or at least the full anterior bundle, was torn. Additionally, there was an exploration of repairing this ligament. If we open up the medial side of the elbow surgically and stitch the ligament back together, and then immobilize the patient to allow it to heal and try to progress them back to throwing, we saw the same outcomes. The outcomes of a medial collateral ligament repair, at least historically, were not nearly as successful. And so they were about the same as the non-surgical treatment. So historically, this was a completely devastating injury. And for most pitchers and overhead throwers, this was a career ender. And so while we tried to treat them non-surgically and even surgically with repair, the outcomes just weren't satisfactory. And so that led to the birth of the Tommy John surgery. And so we'll go through some of the history of that here, which is very pertinent because we're just now just past the 50th anniversary of the first Tommy John surgery. So who was Tommy John? So the interesting thing about this particular procedure, and I laugh about this all the time, orthopedic surgeons love to name things after themselves, name procedures after ourselves. We name physical exam findings after ourselves. And even historically, different parts of anatomy were named after the surgeons who discovered it. But this one's unique. This surgery, Tommy John surgery, is named after the athlete. So Tommy John was a professional pitcher from 1963 to 1989. And he sustained a high-grade, full-thickness ulnar collateral ligament injury in 1974 while he was playing for the Dodgers. And so at the time, Frank Jobe was the Dodgers head team physician, who is now a very famous surgeon and was relatively famous at the time as well, and thought of at a high level in terms of his abilities as a shoulder and elbow and sports medicine surgeon. And he discussed with Tommy John that the nature of his injury and that it was expected to be a career-ending injury. But he also discussed that he had been experimenting, at least in the cadaver lab, with a reconstructive surgery to use a tendon from the pitcher's arm to reconstruct the ulnar collateral ligament. And that's an important distinction when it comes to orthopedic surgery terminology. So we call it a repair if we're stitching the ligament or stitching the injured structure back together. And we call it a reconstruction if we're using some piece of tissue or some piece of synthetic tissue to reconstruct that ligament or make a new ligament. And so he discussed consideration of using a forearm tendon called the palmaris longus tendon. The palmaris longus is largely thought to be a vestigial structure that we don't really use in modern life very much. And it has been used in various other parts of the hand and wrist to be reconstructed. And so Dr. Jobe knew that you could safely use the palmaris by removing it, and it wouldn't diminish the function in the hand. And he thought that he could reconstruct the ulnar collateral ligament or the anterior band of the ligament by drilling a hole in the ulna and the humerus and reconstructing this. But he was very honest and upfront with Tommy John. And he told them that we could do this experimental surgery and it would be truly experimental reconstruction, had never been done before in a throwing athlete. And he estimated that the chances of success with this operation would be about 1 in 100 at best. He thought there was about a 1% chance that this would restore the stability on the ulnar or medial aspect of the elbow and allow Tommy John to return to pitching. And Tommy John said, I'll take those odds. I'm happy to try it. And that seems like a simple decision because it was either do the surgery or his career was over. But the reality is that ulnar collateral ligament injuries are only limiting to overhead throwing. And so had he chosen to retire and move on, he likely would have lived a relatively normal life and would not have been expected to have pain and limitations on the inside of his elbow. And so he was willing to take a risk on having an injury to a nerve, damaging something, or making his elbow worse if it meant that there was a chance that he could continue playing. And so despite Dr. Jobe telling him that he thought it was incredibly low odds of success, he elected to take that risk and proceed with the reconstruction. So his reconstruction was completed in the fall of 1974. It took a full year for him to recover. And so it was over. He missed the entirety of the 1975 season. but was able to return to pitching in 1976 and went on to pitch an additional 14 seasons thereafter and pitched in 164 games thereafter. So it was truly a remarkable outcome. And so this was the original Tommy John surgery. And so this was very different than what's done today, at least in technical terms. So this was a highly invasive surgery, a really large incision on the inside of the elbow. Had to remove all of the forearm muscles off of the bone to detach them and expose the inside of the elbow. Had to move the ulnar ligament, or I'm sorry, the ulnar nerve out of the way, and then created this figure of eight reconstruction, looping it through the ulna and the humerus to attach it, and then put all of that back together. And so this was a relatively morbid procedure. This was really taking apart the elbow to reconstruct the ligament and put it back together. And so if you look at that timeline and progression, the injury was sustained in 1974. Surgery was later in the year in 1974. Tommy John missed all of the 1975 season, as I mentioned, and then was able to return to playing. And even after that successful outcome, Dr. Jobe wasn't quite convinced. So he waited an entire 2 years. And it wasn't until Tommy John was successfully pitching back in baseball in 1976 that he was willing to consider doing the surgery again. So Brent Strom was the second ulnar collateral ligament reconstruction reported in 1976, well after Tommy John had recovered and returned. And so I give Dr. Jobe a lot of credit. This wasn't something he was willing to be cavalier about. He said, we'll try this one time and we'll see how this goes. After he was confident that Tommy John was able to restore his function and get back to throwing in baseball, he was willing to try it again and did it again in 1976 with a successful outcome. Ultimately, from 1974 to 1986, Dr. Jobe was really the only surgeon doing this surgery, at least in high-level throwers or professional throwers. And he had 16 patients, and 10 of the 16 were able to return to their prior level of throwing. And so their prior level of competition, whether that be college baseball or professional baseball. And this was a really successful outcome compared to nearly 0% with the non-surgical treatment. But even at that time, just about 2/3 of those athletes were able to go back to throwing. So despite it being a significant improvement from the non-surgical treatment, this was far from a perfect surgery. The surgery after that series came out in the late 80s began to gain popularity. So Dr. Charlie Conway in 1992 published a series of 30 or 40, I can't remember the specific number of these, and had similar outcomes. 65 to 70% of the athletes were able to return to their sport and throwing. And so now that we had some outcome metrics and some study of the outcomes, we were able to have a much more honest and informed conversation with the athletes about the expectations of surgical management. And so this is where things really started to take off. And so despite the first surgery happening in 1974, this was far from a common surgery up until at least the 1990s. And one of my partners here, who's actually a Northwestern alum as well, Dr. James Hill, was a fellow with Kerlan Jobe in the late 70s. And he said when he was a fellow there in the late 70s, he maybe saw 4 or 5 of these surgeries, no more. This wasn't a common surgery that was being done on a routine basis. It was for very select situations for athletes who had significant injuries, who were unable to return to play despite non-surgical treatment and really were out of options. For those willing to take the risk in surgery, this was something that Dr. Jobe performed, but it wasn't common. It wasn't a regular part of the treatment algorithm for these injuries at that time. So where do we stand today? So what was the evolution of this surgery from the late 80s and early 90s to now? So in the 90s, we saw a significant growth in injury diagnosis. And again, whether that was because the injuries were happening more frequently, performance and pitching were changing, or just that we better understood the injury and we had a treatment. It's often, you see this in medicine, that you'll see a lack of diagnosis of problems with no treatment. And what I mean by that is that when a pitcher would blow out their elbow, well, if they couldn't rest for a few weeks, then get back to throwing, it was presumed that they were done. There was nothing that could be done. It was presumed that they had injured their ligament and their function could not be restored. And so we weren't routinely diagnosing this with MRI and others because it just didn't matter. There was nothing we could do about it. But in the 90s, once we started to realize that there was a treatment that could help these athletes, we started to look a little bit more critically and started to diagnose this more frequently. And so through the 90s, there was a significant increase in the volume of this procedure being performed, driven largely by Dr. Conway, who I mentioned earlier, Dr. Frank Jobe, and then Dr. James Andrews in Alabama, or at least in Birmingham at the time. And so The three of them were performing this surgery routinely and had pretty successful outcomes. And again, in those, at the time, 60 to 70% and climbing to 70, 80% of the athletes being able to return to pitching thereafter. And then throughout the late 90s and early 2000s, we developed significant improvements in the surgical technique that really diminished the morbidity of the surgery. So we discovered that we were able to do this through a muscle splitting approach, where instead of having to detach the muscles entirely off the bone, we can make a small split in the muscle, spread the muscle fibers out from themselves, access the ligament, and create the reconstruction, and then allow the muscle to heal over the top without detaching it from the bone. We discovered that we did not necessarily need to do anything with the ulnar nerve, since we weren't drilling into the backside of the bone. And then in the early 2000s, Dr. Alchek at HSS in New York described the docking procedure, where instead of a full figure of 8 multiple tunnel reconstruction through the bone, we were able to just create a single tunnel with small exiting points. And this actually had improved biomechanics. So it was a stronger reconstruction. And we thought that that would allow us to be able to rehab these athletes more aggressively and maybe shorten the recovery timeline. Like I mentioned, the original recovery timeline was nearly 2 years. It was at 18 months at minimum, and it took Tommy John nearly 2 years to get back to pitching. And we were able to drive that recovery timeline down to about 12 to 18 months. And so the surgery itself evolved quite a bit from a technical standpoint. And these were being performed more and more commonly, and the outcomes, especially at high volume centers, were continually improving. And so over time and over the last 50 years, we've seen rapidly increasing rates of injury, increased surgical indications. And so that's been a large change that has happened over the last several years. And so we've really seen where the indication has changed. The initial indication for this surgery was measurable laxity in the elbow, where you would stress the elbow and it would gap open, or you would put it under x-ray and it would gap open 5 to 7 millimeters, or you would do an ultrasound to prove the gapping. But these were high grade injuries where the ligament was completely trashed or completely ripped in half and totally dysfunctional. Our indications since that time over the last 50 years, the majority of these now are being done for subtle instability, and many are being done for predominantly for pain, even without significant instability. And so, the reason that we've driven and expanded the indications for the surgery is that over the late 90s and early 2000s, we saw more and more incidents of this injury, and more high-profile pitchers, John Smoltz, Billy Wagner, A.J. Burnett in the 2000s, had this injury, had successful surgery, and were able to return to a high level of performance. And so we became more confident in it as a treatment and became more confident in the outcomes. And eventually, through the late 2000s, we saw the outcomes of the surgery drift up to where the 80 to 90% of athletes were able to return to their previous level of sport. And it's an important distinction. That meant they were able to return to playing. And so if they were a professional baseball player, they were able to get back to the professional level, but not always at the same exact level of performance. And so there was still improvements that could be had. So overall, there was an improved outcome. And then in the late 2000s and into the mid 2000s, this became incredibly popular in the popular media. So we started seeing a lot more coverage of the Tommy John surgery, of the increasing number of athletes having this surgery. And we saw some athletes coming back throwing harder than they were before surgery. And so there became this craze of, should we be doing this prophylactically? Meaning, should we be taking young athletes who have been throwing for a long time and be doing this surgery to improve their performance? Fortunately, and what I strongly agree with, is there was significant pushback from the orthopedic surgical community about that. This is not a surgery that makes athletes better. This is a surgery that can restore or help restore function for injured athletes, but it's not a performance improving surgery. And what we've learned over time is that those athletes that came back throwing harder than they were before, many of them had a drift in performance prior to their injury. And so there were those players that were throwing in the low 90s would drift down into the high 80s. And we think that was a harbinger of their upcoming injury. That was sign of a fatiguing and failing ligament that wasn't able to maintain the force and velocity necessary to throw at a high level. And so we saw a dip in velocity, and what we were perceiving as a performance improvement was really just restoring those athletes back to their highest level or previous highest level of performance with a competent ligament in the elbow. And so this surgery does not improve performance. And so, but this is something that we've continued to evolve with over time. Our surgical techniques have evolved. And I think most currently, the biggest evolution from the early 2000s to about 5 years ago was more aggressive surgical indications. That this is now a surgery for athletes who have, we even describe ulnar collateral ligament insufficiency, meaning there's not a full tear on MRI and they don't have gapping on a stress exam, but they have medial elbow pain that prevents them from throwing at a high level. And we have learned that that is because of an insufficient ligament. The ligament's there, it's still attached, but it's stretched out and it's not enough to create the stability on the inside of the elbow that they need to perform at a high level. And so some athletes are even having this surgery just for chronic medial elbow pain that prevents performance that is not resolving. And so the indications have really expanded, meaning we're doing a lot more of these surgeries, but the outcomes have held. And now we expect between 80 and 90% of athletes to return to a high level of function and a high level of performance after this surgery. The downside is that the recovery and rehab is still very, very long. We quote a timeline of a year, but if you look functionally at the outcomes, these are often 12 to 18-month recoveries. And the discussion that I have with our athletes is that it's a 12-month recovery for a pitcher to return to pitching if there is no hiccups along the way in the rehab. But if you take an athlete who's been throwing at a high level for years, for 15 years of their life, they've been throwing at a high level, and then they go through a major surgery where they're largely shut down for 3 to 4 months after surgery, and they start a progressive throwing program at 4 months. They frankly have not been in a situation where they are not throwing for 5 or 6 months almost ever in their life, or at least that they can remember. And so they may have some hiccups. They may develop some shoulder pain or soreness along the way and have some setbacks where they're progressing their throwing, but then they have to step back a little bit. So it can become a little 2 steps forward and 1 step back. And so it's not uncommon to take 18 months to get an athlete through a full rehab after an ulnar collateral ligament reconstruction. And so we've been studying and learning more and more and more over time of how do we speed up that timeline? What can we do differently? Is there something we can do technically? Can we be more aggressive in the rehab? And what's come back up more recently, and again, a lot in the popular media about this, is revisiting the idea of repairing the ulnar collateral ligament. So I discussed earlier the initial outcomes for ulnar collateral ligament repair were not very good. We weren't able to successfully or reliably get athletes back to the high level of throwing that we did previously. But Jeff Dugas, who is a descendant of Dr. Andrews in Alabama, really popularized and pushed about 10 years ago the idea of what if we did a repair but with better techniques? Are we better now surgically? Do we better understand these injuries? And is there a way that we can repair this ligament rather than reconstructing it, which may allow the ligament to heal faster, which may allow us to be able to be more aggressive with our rehabilitation and recovery? And in a lot of credit to Jeff, he was very responsible with how he went about this, very similar to how Dr. Jobe was 50 years ago. He started with injuries that are what are called avulsions, where the ligament is just pulled off the bone, but the whole ligament's healthy. And many of us who do the surgery, from time to time, you look and you say, gosh, that ligament looks okay. It's just not connected to the bone anymore. It sure seems like we should be able to repair this. But knowing what the outcomes are, many of us still reverted to reconstruction because we were concerned that if we repair it, then the athlete might not have the outcome we're hoping for. And this is just unfortunately not a situation where the athlete can afford to fail. If we do a repair and it fails 6 months later and we do a reconstruction and now it's 12 to 18 months, 2 years out of baseball, for most people, that's career ending. There's no opportunity to go back to baseball or overhead throwing thereafter. And so when Jeff started popularizing this, he did it in athletes who couldn't do a full timeline of rehab, meaning a senior in high school who is not going to play beyond the following year unless they pitch that year. So it's either they do something that allows them to get back in less than a year, or they have no treatment whatsoever. He started offering some of those athletes with the right pattern of tearing a repair. And again, he studied his outcomes and saw good outcomes similar to Dr. Jobe, and saw these athletes returning to throwing a little bit faster, and started to expand that, where there are more tears that can be repaired. And now in the last 5 years, we have seen an explosion in ulnar collateral ligament repairs. And so this is, again, different from a reconstruction. This is stitching the ligament back together. And then a lot of you have seen with a quote unquote internal brace procedure. And again, this is where my conflict comes into play. The internal brace is an Arthrex trade name. And so it's a product made by Arthrex. And what it is, and it's pictured here, is a piece of high tensile strength braided polyethylene suture that is connected to two suture anchors, which are like little plastic screws that go into the bone. And it's thought to be like a seat belt. You stitch the ligament back together, and then you put this in there to protect that repair. So when the elbow sees some stress, it can't stretch out as easily because the suture helps prevent that while the ligament heals. After the ligament heals, the hope is that it goes back to relying on the ligament for the stability and not the stitch. But what we've seen is that these athletes are able to get back faster. And so instead of 12 to 18 months, it's often 6 to 12 months return to sport. And again, at the professional level, that's important. But for some young athletes who are hoping to play in the next level, a shorter timeline may afford them opportunities to do so, to where a year-long recovery, they miss a season, they aren't able to be recruited, and they're unable to play beyond their current level. And so the faster rehabilitation has been an exciting thing. And this is something that's still very new. And so far, the available outcomes are very exciting. And we're seeing more and more and more repairs. Not as many of those athletes have made it through to the professional level because these are things that were done when they were in high school, but we're starting to see them drift into the professional level. So a few years ago, we would say, we know of good outcomes with repair, but we haven't seen any professional pitchers in our organization, at least with repairs. Now we're seeing those come through. And so there's been an explosion of these repairs, and we think this may be the next wave of managing this injury. And again, I don't think it'll entirely replace reconstruction, but there are probably some of these that can be repaired successfully with a shorter recovery timeline and as equal or better outcome to a reconstruction. And so that's a very exciting front. Now, there's also challenges in the evolution here. The explosion of these injuries has led to a lot more revision surgeries. So the athletes are having a reconstruction or a repair when they're 16, and then they're re-rupturing as a professional athlete at 22 or 23, and then they have a revision surgery. And there's even some professional baseball players now pitching in Major League Baseball on their third ligament. They had a rupture and a reconstruction, and then a re-rupture and a revision, and then they re-ruptured again and had a revision, and they're still getting back to playing. Now, the outcomes are much, much more variable when you get into the revision setting, but we're seeing successful outcomes. Even in the multiple settings, and those can be challenging because it's a much less predictable surgery the third or fourth time over. So case example here of a recent patient we saw in the last few years here at Northwestern. So 16-year-old male who came in to see us in the office and had medial-sided elbow pain for a year. Separately from this, he had been dealing with a back injury. And so he had had a true 4-month period of rest and rehabilitation, but was still unable to get back to throwing. And when we looked at his elbow, he had a high-grade partial tear in his ulnar collateral ligament that's pictured here. Now, another evolution for us has been how we image these. We're now able to do stress MRIs where we're able to put the patient in a position that puts some stress on that ligament. And when we did a stress MRI called a fever view on this patient, he opened and he gapped medially. So we had a discussion with him and his family regarding his injury. He had already been unable to return to baseball despite his medial sided injury. We were able to diagnose his injury on a stress MRI here at Northwestern. And then we talked to him about options, and he elected to proceed with an ulnar collateral ligament reconstruction. And so as a 17-year-old, he's now back pitching at a high level, throwing in the low 90s, and optimistic about throwing in college. So when these go well, they go very, very well. And that's becoming more the expectation and more the norm than the exception. And it's very, very exciting. So briefly understanding, so who is at risk for these injuries? So there's a lot of things that are associated with this. It is nearly impossible to predict how, when, and where these injuries happen. There's not great imaging studies that are predictive. We do this a lot in our assessment of players we're going to draft. So in about 10 days, I'll be at the Major League Baseball Combine in Arizona. We'll evaluate about 200 high-level throwers, and we'll look at MRIs and imaging and all different kinds of studies. We still can't predict who is going to rupture and who is not. There's an increasing number of re-ruptures as velocity increases. And so we've seen that in Major League Baseball. As velocity has drifted up, we've seen an increasing incidence of ulnar collateral ligament injuries. Pitching volume, especially in youth athletes, seems to matter. So pitch counts, how many pitches is the athlete throwing and how frequently, what are the periods of rest? And then arm slot, where the hand's positioned in space. We know that arm slot has an impact on the amount of force put through the medial elbow. We think that it's associated with an increased risk of tearing the ulnar collateral ligament, but that's much less definitive. There's a lot of athletes pitching successfully in a variety of arm slots, but these are the things we think puts athletes at risk. So how do we prevent these, and where are future directions going forward here? So I think preventing these, like I mentioned, the Major League Baseball at the end of 2024 did a large investigative analysis because we're seeing increasing rates of these at the professional level. The stat that I saw yesterday was that over a third, 33.5% or 35%, I'm sorry, of professional pitchers currently in Major League Baseball have had ulnar collateral ligament surgery of some sort, whether that's a repair or reconstruction. So a third of our professional athletes have had an injury here. And we've seen increasing velocity. Fastball velocity average in the league has climbed 3 to 5 miles an hour over the last 10 years. And so this is a relatively significant increase. We are routinely seeing athletes throwing 95 to 100 miles an hour now. And we think that is part of what has increased the risk of the injury. And in the youth game, we're seeing increasing velocity, increasing pitch variety with breaking pitches and other things like that, and increasing pitching volume. I saw a 13-year-old in the office this past week who throws over 90 miles an hour. He's 13 years old. It's truly incredible. But as performance has increased, as we better understood performance, as we better understood high-speed camera motion analysis and how to make this a more efficient movement, we're able to get athletes throwing harder at younger ages, but we're also seeing an increased amount of injury from that. And so what we have to figure out with time is how do we chase performance without the increase in injuries. And that's where we're at now, is working towards, no one is excited about diminishing performance, right? No one's excited about how do we make pitchers throw slower or throw less effectively. What we want to figure out is how can we allow them to perform at that high level and diminish their risk of injury. And so at the youth level, there's a few things that have been rolled out. And so Pitch Smart is a combined effort between USA Baseball, which is an amateur organization, and Major League Baseball. And it's a collaborative effort of how do we diminish injuries in young players. And so this is the organization that has been behind pushing for pitch counts for young throwing athletes. And they have a flow chart and a recommended chart for volume of throwing by age and about expected rest. And so managing pitch counts, ensuring that athletes have appropriate rest, and in managing throw count. And that's different because oftentimes at the young level, the pitcher who throws hard, that 13-year-old who throws 90 plus miles an hour, is also a good athlete and is also playing other positions on the field. And so if we have a pitcher who throws 80 to 100 pitches and then subs out of pitching and goes and plays shortstop and throws another 30 throws across the diamond, there's probably an impact to that. And so we have to be cognizant of the total throwing volume and then fighting against sports specialization. This is an ongoing problem in all sports. We know that sports specialization leads to increased injury and risk profile, but the nature of traveling teams and showcases and other things have led to more and more and more sports specialization over time. And so trying to figure out how do we get athletes, to be multi-sport athletes, to cross-train, because we think that that can diminish their injury risk, but the current environment functionally discourages that. And so pushing back against that a bit. So in summary, Tommy John, Frank Jobe was an innovative surgeon, and Tommy John surgery was an innovative procedure with a surgeon and an athlete willing to take a risk. And I don't mean that to sound irresponsible. Frank Jobe was a master surgeon and an excellent surgeon. The risk was we're going to do this big operation with this long recovery, and we're not sure if it will get you back to baseball. And Tommy John was willing to take that risk. And I did not know Frank Jobe personally, but from all of those I did, who knew him, said there's no surprise that this surgery is named after the athlete and not the surgeon. That's just the kind of person Frank was. In his mind, he did very little, and it was Tommy John who did put in all the effort and the time and the rehab and all of that. This procedure revolutionized sports medicine and baseball. It's pushed us to chase higher performance and to figure out what can we do to allow athletes to continue to perform at a high level. And so we hope with continual innovation, we'll be able to improve outcomes even further and chase even higher than that 90% return to sport rate. And then really the holy grail will be how do we figure out to continually improve performance without the injury risk? And that's, again, where the efforts are currently, is those two. Continued innovation in the surgical management, but also on the preventative side. As much as we love doing these surgeries, we'd much rather see the athletes be able to perform without injury. And so continuing to push in that direction. So with that, thank you very much, and we will open up for questions here in the last 15 minutes.
Thank you, Dr. Buchler, for that insightful presentation. We're going to move on to questions. Our first one, submitted by an audience, says, I'm curious how often this procedure performed on pediatric patients, given the increase in occurrence even at the youth level, and how does recovery and outcomes differ? Thank you.
So it depends. So the issue in pediatric patients, is that the growth plates around the elbow close very late. And so you don't actually see this injury often in young athletes with open growth plates. They are much more likely to sustain an injury called a medial epicondylar avulsion, where the muscle and the ligament that attach to the bony prominence pulls off the bone. And we are seeing an increase incident in that as performance has gone up. So as we see these athletes with open growth plates throwing in the 80s and 90 miles an hour, they can pull that bone off because the cartilage in the growth plate is the weak point rather than the ligament. Once that growth plate closes, then the weak point becomes the ligament. And so you'll see that this injury, again, it is described in athletes who have open growth plates of no bony avulsion and a ligament injury. And frankly, no one is quite sure the exact right way to manage that. And so we often see that managed with a repair because our concern is that our reconstructive techniques would violate that growth plate and alter the growth about the elbow, which can lead to deformity around the elbow. And so, but we will see those medial epicondylar avulsions, and we see them with increasing frequency. And typically, if they're avulsed and they come off with any sort of displacement, so occasionally there'll be an injury and it doesn't move out of place. But if it moves out of place and it travels down the elbow, we will typically treat those surgically with a repair to restore the tension on the ligament and replace the attachment of the muscle.
Got it. Thank you. Our second question is, how common are re-tears post-surgery, and how do the rates compare between repairs versus reconstruction?
So good question. So it depends on how far out you are from surgery. And so the rate of re-tear increases significantly after about 7 or 8 years. And so there's been an increasing concern in baseball as these surgeries are being done on younger and younger athletes. So for example, if a patient has a reconstruction at 14 or 15, most of our professional pitchers are in their early 20s. And so if there's a reconstruction at 14 or 15, those pitchers are at risk of re-rupture, and that's becoming increasingly more common. We don't have a hard number on that in terms of what are the chances of re-tearing, but the more volume we see, the more frequent we're seeing re-tearing. And there's been evolving management of how do we manage the re-tears. And so the re-tear rates, so historically, those would be treated with a revision reconstruction, either with a hamstring tendon or a cadaver tendon or something, some other form of tissue. But there's been increasing popularity in the last 3 to 5 years of actually repairing the reconstruction. And so going in and repairing the reconstruction back to bone because that tissue is now integrated into the native elbow tissues. We don't know the number on the risk of re-tear after a repair. We are still waiting to figure that out. The challenge with that is that we expect to see a similar timeline to reconstruction, but repair has really only been popular for the last 10 or so years. And so we're going to need a few more years to really see large volumes of those. But the current data is that the repairs that are able to get back to throwing seem to have similar return to sport rates as reconstruction, so around 90%. And there's no evidence as of yet that they definitively have an increased failure rate or a shortened failure timeline. And so we think that there may be some upside to a repair, but the challenge with that is there's a huge amount of what we call selection bias in who is being repaired. So repair may not be the answer for every tear. We know that Dr. Dugas and a number of others who were early adopters on this were initially very, very selective with what tears were being repaired. And so there's a little bit of a perception now that, well, maybe a repair is just better than a reconstruction. Maybe all tears can be repaired. And I think there's still some hesitancy with that. With true mid-substance injuries, there's still a bit of hesitancy with repairing only. But what has become a little bit more popular is what's called a hybrid reconstruction, which is a repair with a reconstruction. And so trying to get kind of a best of both worlds situation. And so for those tears that truly pull off of bone, there's several folks doing a primary repair without a reconstruction. But for those mid-substance injuries, many folks in my own mindset is that those are probably best treated with some sort of hybrid treatment with a repair and a reconstruction.
Fascinating. Um, Moving on to our next question. How did Tommy John's successful return to pitching change the mindset of athletes, teams, and doctors around sports injuries and recoveries?
I think the biggest thing So specific to this injury, this was a career-ending injury. A pitcher would feel a pop in their elbow, they would walk off the mound and know they would never pitch again. And you would see the devastation on their face. There's countless pictures of walking off the mound, head hanging, glove in their hand, walking off the field, looking around the stadium, and knowing that that was the last time. And they knew it because they had seen their friends go through it and they had seen others go through it, and they knew they'd give it their best and there would be their best effort at rehabilitation, but they were likely never going to pitch again. So that mindset has definitively changed. Don't get me wrong, no one is excited about rupturing their ulnar collateral ligament, but the outlook is much more optimistic. And so that part I think has changed. And I think it's probably changed, indirectly changed sports medicine a bit in that I think we are a bit more aggressive with doing big surgeries on athletes with bad injuries and giving them a chance at getting back. And whether that's in the knee or the shoulder or the elbow, historically, returns to the kind of pinnacle of performance post-surgically is not reliable. And I think that's still true. There's no doubt in my mind that there's no surgery that we have that undoes the injury. We can't make a person uninjured. All we can do is hope to restore their function and performance as best we can, but we probably can't make them as good as they were before they were injured. But I think we've become a little more aggressive about giving the athletes that chance, even with bad injuries.
Brilliant. Thank you so much for the explanation. Our next question is, as a team physician for the Chicago Cubs, how often do you encounter cases where Tommy John surgery is considered, and what goes into that decision-making process?
Um, Unfortunately, with professional baseball in a large organization, you have a couple hundred athletes in the organization. This is an incredibly common conversation. And so, we at any given time at our rehab and training facility in Arizona, we may have 10 to 15 athletes recovering from ulnar collateral ligament surgery. And so this is an incredibly common part of the conversation. Now, at the professional, at the major league, big league level, fortunately, it's rare. But I mean, it's not uncommon for us to have a season where once, twice a year, one of our major league pitchers has a medial elbow injury, and there's a conversation about how to manage it. And frankly, with the league's drift towards increasing velocity and performance, I mean, the science behind function and performance has grown exponentially. The biomechanics labs that every major league team have in Arizona would rival the best academic and university biomechanics labs in the world. And so we've really, really learned how to push the body for performance for throwing. But along with that, we've seen an increasing number of injuries. And so it's unfortunately almost an expected part of taking care of athletes and playing baseball at the highest level. And I mean that from an organizational perspective as well as from the athlete's perspective. The athletes recognize that this is something that there's a definitive risk of. And so no one is particularly surprised. Now, the unfortunate part is we just can't predict when and who. We can't tell someone, oh, you have X, Y, and Z characteristics. That means your likelihood is this for this season or the future. But I think most of our pitchers recognize that it's a risk and it's an accepted risk. But I think it's an accepted risk and or it's more of an accepted risk and less of a fear because the outcomes of the treatment have improved so much.
Gotcha. Well, speaking of progressives and progression in technology and in sports medicine, can you tell us what excites you most about the future of sports medicine?
I think there's a lot of things that excite me about the future of sports medicine, specifically with relation to ulnar collateral ligament and Tommy John. I think what excites me the most is I think we are starting to get to a tipping point where we've had this surgery that's been relatively the same for 50 years. It's been good surgery, it's improved outcomes, but we're just starting to get to the point where the outcome of the surgery today may be different than it was, say, 20 years ago. And what I mean by that is that we may be able to figure out ways to accelerate the rehab timeline. At the professional level, losing a year is a huge deal. However, that is career ending for many amateur levels. So depending on timeline, a sophomore in high school that ruptures, well, they can miss their junior season and then play their senior season. So they still have an opportunity to continue playing. But an athlete that ruptures their junior season and misses the entirety of their senior season probably isn't going to have an opportunity unless they were an elite tier performer prior to that. And so, and you see the same thing in college. Athletes that have this injury early on have an opportunity to recover and continue playing, but those that have it late can often be career-ending. And so, if we're able to better understand which of these ligament injuries can be repaired, which can we be more aggressive on rehabilitating and allowing to progress back to sport faster, I think we can probably improve outcomes. So I think that's one thing I'm very excited about. And the second is, can we better understand the biomechanics of this injury to come up with a prevention program? So we know that some of the pitch count stuff and the appropriate rest things work in terms of lowering the numbers, but I would compare this to anterior cruciate ligament anterior cruciate ligament injuries in middle school and high school athletes. Prevention programs work. Some studies show that in ACL injuries, a good prevention program can diminish the risk by 20 or 30%. And so I'm hopeful that we can develop the same approach to ulnar collateral ligament injuries in the elbow and really prevent these injuries. We first have to understand the injury, then we have to figure out how to treat it. But as we understand more and more and more about the injury, we can get to the first step, which is preventing it from happening altogether.
Wow, thank you for sharing your hopeful insights. Our final question is, have there been studies using grafts from ligaments other than the palmaris longus to perform the reconstruction?
Yes. So this is not nearly as well studied in the ulnar collateral ligament as it is in the anterior cruciate ligament. Most all of us prefer an autograft, meaning a graft coming from the patient rather than a donated cadaver graft, which is called an allograft. And the vast majority of these are done with palmaris longus autograft or a gracilis tendon autograft, which is a hamstring graft. And we have a very low threshold to use a gracilis here. What we know about other ligament reconstruction is that the diameter of the graft matters for re-rupture risk. We don't have that data in ulnar collateral ligament surgery to predict the diameter of the palmaris, but we can typically tell on physical exam if the patient has a robust palmaris tendon or not. And if there's any questions about it, or in up to 15 or 20% of throwers, they will have no palmaris tendon. We will use a hamstring graft or a gracilis graft, and we've been very satisfied with the reconstructions with that. It's a very stout, bulky ligament that we think restores the native anatomy very nicely.
Wonderful. Well, on that note, thank you so much for everyone to joining us for today, and thank you again for Dr. Buchler for the wonderful presentation. To find out more about alumni events, please check the NAA website at alumni.northwestern.edu. Have a great rest of your day and go Cats.
Thank you, everyone. Have a great day.